prostate and during robotic surgery and what we can do to try and define the anatomy better while we are operating. In fact, I'm just about to give a talk on flying in the patient's MRI, whereby you can see where the tumor is, you can see where the nerve bundles are. Can we do this in real time? The answer is yes. Is it effective? Do we have the technology yet? The answer is not quite. But we do know something from cadaveric anatomy that is for real. And the first statement that is of importance is simply this. Every prostate is slightly different. So you have to adapt your approach to each and every prostate in a slightly different fashion. Starting with, for example, the apex. If you see this, most of the APCs will look like this or like that. But I have often been caught out with an apex which is protruding at the back, and if you have a tumor which is protruding posteriorly and you haven't spotted it, you're going to get a positive margin because you're going to cut across it. So there are little tricks that you can employ, which I'll show you when we show the apical dissection, as to how you can avoid cutting across this kind of an apex. The most difficult APCs, I think, are the notched apex, which are either externally notched, and again, you can cut across this. You may accidentally cut more of the sphincter here while approaching this kind of an apex, or the inwardly notched apex, where you can also accidentally get a positive margin. Now, you will all remember this. Remember that the sphincter is like a horseshoe, so it is deficient at the back. Okay? So while you're cutting across here, remember this is the weakest point of the sphincter. And it is best, therefore, if you do not dissect too vigorously in this part of the anatomy. So these are things that we can learn despite the increase in technology that is happening on a regular basis. The second point to remember is that if you see an accessory pudendal vessel, and they are never in the same place, some will run across the prostate like that, you have to protect them. Some will run under the vata fascia. Others will be further up, and some will actually give a branch from the inferior epigastric and just try and come into the prostate. Clearly, in this situation, you have to take care of this because this is a vessel directly going into the prostate, but preserve the rest. So if you see the accessory pudendals, do not automatically just clip them and remove them. Take your time, dissect them if you can, and move them away from the body of the prostate and the apex. The final thing to tell you, which you're very interested in, is that the nerves to the prostate are like a hammer. The prostate is thought to grow into the nerves, just like this lady sitting on a beautiful beach in Hawaii. So it's literally pushing the nerves laterally, and that's what we think happens in the embryological situation. Why do we think that? If you look at this, and this is only visible in a cadaver, I have never seen this kind of a picture in real life. I'm sure Thierry and Walter haven't either. You can't see these because they are covered in so many layers of fascia. But in a cadaver, which is preserved, you can see that the prostate has literally grown into this hammock of nerves and has pushed the nerves out. So there is crosstalk between the nerves from the left and the right side, the neurovascular bundles, which we just do not get to see as the prostate pushes into the nerve bundles. There are three kinds of nerve sparing traditionally described. The first is the intrafacial, where you're literally hugging the capsule of the prostate. I think this is only acceptable in patients where you have low volume Gleason 6, for example, on one side where there is no palpable disease and where you can be fairly certain on your MRI scanning, which is increasingly being done in these patients preoperatively, that there is no tumor on that side. The other is the extrafacial. This is actually a non-nerve sparing procedure. This is along this line, which is the purple line, where you get rid of the nerve bundle completely, and again this is impalpable disease, or where the MR is suspicious of P2 tumor in that area. And you can see this is the typical unilateral excised nerve on one side with the preserved nerve on the other. With the intrafacial, you see this glistening surface of the prostate. The one which I prefer more and more, because I have a lot of locally advanced disease, is the interfacial nerve sparing. This is typically a patient where there is no palpable disease. It's Gleason 3+4. You have seen an index tumor perhaps on the MRI. It is within the capsule. It is not averting anything dangerous, and you can safely leave an extra layer of fascia on the prostate, and that is the kind of appearance that you get on the specimen at the end. Remember that despite that, you can never be 100% certain that you will get a negative margin. So there's a judgment call that you have to make for each and every patient. I insist when I walk into the operating room that the details of the patient and their tumor, their MRI, what is palpable, what is not, what is the Gleason, is written on a board in front of me. Because, as I said, the operation is slightly different for each patient. You can see here, there is a patient who had a beautiful intrafacial nerve sparing. See how close the tumor is to that ink margin. It's literally less than a millimeter on the microscope. So you have to be extremely, extremely careful in the kind of nerve spare that you choose. Now, this is also very controversial. There's a lot of cadaveric work which comes out of Australia. This is from Tony Costello, and I just wanted to share this with you because his views are completely contrary. If you imagine this to be the prostate, the levator and the prostatic fascia, this is the fascia of Denon VA, he says that the cavernous nerves are only here, these are the rectal nerves, and these nerves do not go to the prostate at all. So if you look at this is the pelvic plexus, this is the posterior branch, which is the rectal branch, the lateral bits, which we try to save so vigorously when we are doing a veil of Aphrodite. He says these are levator branches, the cavernous nerve is only here, and the most medial branches are prostatic branches. He's not wrong, but increasingly you will find people in the right patient doing a very high anterior spare. We do not know for certain that these nerves are actually from here going to the penis. But if you do a high anterior release, it simply means you have less traction on the nerves here. But there is a controversy about the anatomy, and all that matters may be just the posterolateral nerves. Thank you.